Good evening.
Good evening, all. Good evening. Hi. Hi, Manisha. Acha, Amrapali, everyone is joined. Okay. Good evening, Ghatkade, sir.
Hi. Do we want to? Hi, Amrapali. Do should we just? Do we need to call up Dr. Neglur to join? We'll join in.
Amrapali, I was trying to call you. See, now while playing the videos now, I've given the sequence of the videos. So you say that the first video will be Eva Joshi, or in the recipe you start with Manisha's video. Then he will play the video. Okay.
Yes,
So after you say it now, he'll play the video.
I should say.
Yeah. So you've gone through the sequence now, sequence of the videos.
Yeah.
First is Manisha's video in the recipe. So we'll start after the diet lecture. We'll start with Manisha's recipe. So you say that now we'll start with the recipe videos. So first will be Manisha's recipe. Then second will be um this one's Ashwini's recipe. Then you say that now we'll start with children's video, children and grandchildren's video, and then you say that now it will be Isha Joshi's video. And then Dr. Rajan Joshi, he will introduce, and then the video will be played, right?
117 2628.
Yeah.
और एक 8 है.
Ganesh, Mr. Ganesh, sir.
Yes, madam.
Yeah. तर आता बघा आम्रपाली मॅडम ना ते सांगतील की आता इवा जोशीच्या व्हिडिओ प्ले करतायत आणि देन यू अनम्यूट सो डॉक्टर राजन जोशी विल इंट्रोड्यूस द चाइल्ड and then the video will be played. Okay?
Okay.
So पहिला Dr. Amrapali, then Dr. Rajan Joshi, and then you play the video. Understood, na?
Yes, yes.
Okay, thank you.
मॅडम ग्रुपवर मी युट्यूबची पण लिंक टाकले, एकदा चेक करा मॅडम.
After the recipe videos, we will ask Ashwini to comment on them. है ना Ashwini?
Yes, 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 yes.
Yes, sure. I will. Good evening, everyone.
Good evening.
Good evening, Amrapali.
Hello.
Good evening.
Good evening, sir.
Yeah.
Good evening, sir.
Yeah. Good evening, Arna.
Yes,
All
sir.
set. Hello. Hi, set.
Hi.
All set.
Yes, yes, all set, sir.
I will just share a slide and see.
Yes,
Yeah,
sir.
yes, please.
Yeah, right?
Yes, yes. Yes, we can see it.
Yeah. Okay, great.
हॅलो मॅडम. हॅलो. मॅडम प्लीज एकदा चेक करा युट्यूबची लिंक, ती ग्रुपवर टाकली मी.
हो मी चेक करते हाँ एक मिनिट.
हो हो.
Okay, great.
Should I also check whether my slides are running?
Yes, yes, yes.
Ganesh, it's fine. Only there's a little delay, but that's okay.
हो मॅडम, त्याला डिलेच होतो.
I know. That's fine.
एकदा चेक करा युट्यूबची लिंक, ती ग्रुपवर टाकली मी.
हो मी check करते हाँ.
Okay. This is visible, right? Check whether my slides are running. Hello.
It's fine. Only there's a little delay, but that's okay. गणेश वेबिनार सुरू झाला कीच रेकॉर्डिंग सुरू करा हा.
Yes, yes.
Yeah.
And I personally called Dr. Balaji and Dr. Rajesh both this evening.
Yeah. So, Parna, I have called all the state office bearers, and I sent to this one also, who's Dr. Bajwa and Dr. Diwatia and
Mhm.
Dr. Indrani Madam also. So, Indrani Madam said she'll be in Colombo. She might not be able to join.
Okay.
Dr. Diwatia will be in transit, but he said if I get some time, I will join. And Dr. Bala Venkat is in Bahrain or something, but unlikely. But they've all sent good wishes.
Okay.
Yeah.
I put it up in the president secretary group, so then
And
I
what
read
else
it.
am
And
I-
I've sent it to Manisha Katekar also.
yeah, Manisha also said she will join. And if the webinar is going on and somebody joins na, just chat box में उनका welcome type कर देते हैं without interrupting the session.
Yes.
Yeah.
So after sir's lecture now, then I might have I'll have to leave by 6:45 or
Okay,
something.
you have to leave. Yeah. Okay.
Yeah. So
Because
then
Nilima might also not join in. Her dad is a little unwell, but okay.
okay. So vote of thanks then.
Yeah, I can do that. Yeah.
Yeah. So I'll first you start, then
Yeah.
I'll just give a brief introduction of about the program, and then I'll introduce Amrapali, and then she'll take over, right?
Yeah. Sure.
Okay. Yeah.
ते ग्रे वाले हैं क्या तेरे? नहीं, ब्लैक वाले नहीं, मैंने ऑन
Good evening, Neglu sir, candidate
Good
Ashwini
evening.
Dhole.
Good evening. Good evening. How are you?
I'm good. Sir, ओळखलं का डोंबिवलीची?
Oh, yes. ओळखलं. So nice to see you all.
Yes, sir. Yes, sir. It's a pleasure to be with you on this webinar.
Thank you.
कसे आहात?
My pleasure as well. It is bilateral.
Yes. How are you, sir?
Fine.
Ganesh or Amrapali, would you like to just try the videos whether they are running okay? We have 5 minutes before we start.
You want to check the videos?
Yeah, that's what I said. If we have time, so we can just check whether they are like okay. Good evening, Dr. Avinash Bhosle, sir. So kind
Good
of
evening, madam. I am just traveling.
you are traveling, but you have joined. Thank you so much.
या जॉईन केलेलं आहे मी मधीत काय रेंज जाईल माझी
हाँ, चालेल
हाँ?
काय. Dr. Balaji,
कारमध्ये आहे.
please welcome.
बालाजी
Yeah,
गुड इव्हनिंग. मी ड्रायव्हर आहे
Hello.
त्यामुळे मी बोलू शकतो काय प्रॉब्लेम नाही.
हाँ, चालेल.
Good evening,
Good
Balaji
evening,
sir.
Dr. Balaji.
Good evening, madam.
Good evening, Bhosle sir.
गुड इव्हनिंग.
I may lost
चाललोय कॉल वरनं
signals
परत.
because I am changing. Hello.
हाँ,
Yeah.
yes.
Yes, sir.
Yeah.
No problem.
Just finished OT, but I will
Okay.
continue.
Yeah,
Okay.
sure.
Yes, sir.
Okay.
अविनाश सर सेक्शन के लिए जा रहे हैं.
नहीं स्टेशन से अभी वापस जा रहा हूँ घर.
अच्छा.
अभी जा रहा हूँ देखो वापस.
Okay.
अविनाश सर, हमारे थाना में मैराथन है 14 जनवरी को. आप प्लीज आइए दौड़ने के लिए. डॉक्टर कातकड़े सर इज अरेंजिंग. And I
No,
said I is participating.
actually 28, next Sunday, Mumbai Marathon is there.
The big one.
Yes.
So I register for that meeting, marathon.
एक प्रॅक्टिस रन करायचं ठाण्याला येऊन मुंबईच्या हवा
ठाण्याला?
पाण्याची सवय होईल.
आदल्या दिवशी का आदल्या रविवारी का आदल्या रविवारी आमची रेस्ट असते.
हो रेस्ट असते खरंच.
एक त्यावेळेला जास्त रनिंग करत नाही, पण येऊ शकतो अगदी. काय बघू कसं आहे सध्या शेड्यूल कसं आहे, कारण लागोपाठ 2 रविवार लगेच होत आहेत ना.
नाही एक्झॉस्टिंग होतं सर, बरोबर आहे.
हा. हम्म.
Hi Manisha. Hello everybody.
Hi Shamini. Come.
Hello.
चल ना, बराच अंतर ठेवतोस मध्ये. हॅलो.
Hello. Chalo. Parna, we can start in another 2 minutes, huh?
Okay.
Whenever you say, we can start.
It's 5:59. We'll start at 6:02 or 6:02.
Yeah.
Okay. Yeah. We'll start on time because sir has to leave now.
Yeah.
Yeah.
Dr. Rajesh Tagadpalle has joined. Welcome, Dr. Rajesh, the Honorable Secretary of SAMS.
Welcome, sir.
Chalo. Can we start, Parna?
Yes.
Yeah. Good evening, everybody. I am Dr. Manisha Ghosh, the President of Indian Society of Anesthesiologists, Thane City Branch. We had a very successful last year where we conducted our webinars, our workshops, plus our COLS activities on a large scale. And we were very privileged and honored that we received recognition not only at the state, but also at the national ISA conferences, where we won awards in various categories. So today is the first webinar of this new team, and it gives me great pleasure to introduce our new team who will be with you all for this whole year. Our Honorable Secretary, Dr. Parna Thakkar, who everybody knows very well. She's one of the most dynamic anesthesiologists of the country. Then we have Dr. Katkade sir, who's always been our mentor and guide. He's also our GC member and will be representing our city at the state level. And we have Dr. Nilima Kelkar, who's our treasurer and a very hardworking person. And then there is Dr. Amrapali and Dr. Shamini, who are a part of our scientific team and who are a very enthusiastic lot. So we expect to have a really wonderful year under them. Plus, our whole team is geared up with numerous activities, and we already have a schedule made till I think the middle of next year. So we are all looking forward to having you join us in all our activities. We seek your blessings and your guidance. And please let us know if we are going wrong anywhere and encourage us like you've always done. Now I hand over to Dr. Parna Thakkar, who will be introducing the program to all of us.
Thank you, Manisha, for that kind and brief introduction. So let's get started. Good evening, all. On behalf of Thane ISA, I welcome each and every one of you, all the participants, all the speakers, the executive committee members, our SAMS president, Dr. Balaji Asegaonkar sir, our SAMS secretary, honorary secretary, Dr. Rajesh Tagadpalle sir, and the past honorary secretary, Dr. Avinash Bhosle sir, who kindly joined and made the program more successful. So we'll start with this. 14 November, all over the world, it is celebrated as World Diabetes Day. And it is also the birthday of Sir Frederick Banting, who discovered insulin. Month of November is the National Diabetes Month, and the main focus during this month is to create awareness about diabetes and prevent its complications. So let's celebrate World Diabetes Day before the month of November ends. Diabetes and diet are closely related, and we will also have a small talk about diet today during our webinar to promote healthy lifestyle. 14 November in India is also celebrated as Children's Day. It's the birthday of Pandit Jawaharlal Nehru, who loved children. At the end of the webinar, we will be playing the videos of some healthy recipes, which are the videos which are made by our Thane ISA members. Also, we'll be playing the videos of our members' children and their grandchildren who are super achievers. So I'm very excited about this unique theme-based program, and it's the first program during our first webinar during our new tenure. And we began with the celebration of World Anesthesia Day, and after that, it's the first webinar. So let's get started. Dr. Amrapali Nayak, who's the consultant anesthesiologist at Jupiter Hospital, she'll be moderating the program. So over to you, Amrapali.
Amrapali, you have to unmute yourself.
Good evening, everyone. Let me introduce you to Dr. Vijay Neglur. He's a director of Dr. Neglur Diabetes Specialty Clinic in Thane, consulting diabetologist at Jupiter Hospital, Thane. He has many publications under his name. Over to you, sir.
Thank
Dr.
you.
Vijay.
Thank you, Amrapali, for your kind words. Let me share my slide. I hope the slides are visible and I'm audible, right?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
Okay. So we'll discuss today about new or anti-diabetic drugs as we mark the celebration of the World Diabetes Day. Before we come to the session, I reminded of an important incident, very interesting incident in a flight. In the midst of the flight, the air hostess comes to an economy class and announces, is there any anesthetist on the board? There was a young anesthetist sitting. He was excited and he got up and said, anybody sick? Anybody ill? She said, yes, please follow me. So she took him from the economy class to the business class and stood next to the very famous cardiac surgeon. And the cardiac surgeon looked at that person and said, can you please adjust the light for me because I can't read my book properly. So that's how the anesthetists was used to adjust the light. I know they have been very helping, very hard, especially during the OT times, and they do all kinds of odd jobs. And they are so much important in seeing the surgery through, and talking to them is also very interesting and very nice experience. So thank you once again. And I thank the organizers of the Society of Maharashtra State Anesthesiologists, especially Dr. Amrapali, Dr. Manisha, Dr. Parna, Dr. Nilima, and of course, my close friend, Dr. Sunil Katkade. So why it's important to look at the management of diabetes, especially in the surgical setting. It's important because the length of the stay of these patients in the hospital is longer because of the dysglycemia. And it reminds you that it's most important complication that you get in diabetes, and it's a 7th major cause of death. There are many drugs are involved in treatment of diabetes and its comorbid condition, and especially the patient also receiving insulin has further complications of the treatment itself. Then patient requires most important post-operative and a critical care in patients of diabetes. Certain procedures and surgeries commonly not seen in non-diabetic patients, and have increased mortality and morbidity rates. And surgical procedures result in metabolic perturbations and hypoglycemia. And hypoglycemia risk factor for the post-operative sepsis, endothelial dysfunction, cerebral ischemia, and impaired wound healing. What actually happens in the surgical stress is the stimulation of the counter-regulatory hormones, the catecholamines, the glucagon, cortisol, and the growth hormones. And the surge of these hormones have the effect on the pancreas in inhibiting the secretion of insulin, and of course, on the stimulation of the adipose tissue, which brings about increased lipolysis. That lipolysis flushes the fatty acids into liver, and also because of the excess free fatty acids and decreased uptake of glucose by the peripheral skin, by the peripheral tissue, especially the muscle, the lactate levels go up, which go to liver, and liver desperately converts this lactate into various aspects of glucose, like gluconeogenesis, or does bring about glycogenolysis. There's the increased glycemia again. So therefore, the patient has these problems of glycemia, which gets worsened, and that results into mitochondrial injury, endothelial dysfunction, immune dysregulation, and reactive oxygen species. So these are the problems that occur in the surgical case, and therefore awareness of these problems, and therefore equipping oneself with the proper management is important to see the patient through the surgical procedure. And this is the publication which looks at the glycemic control as a strong predictor for the post-operative morbidity and mortality. And what the study says, that at the end of 30 days, the mortality is pretty high, and plus the increased incidence of the causes of myocardial infarction, stroke, renal failure, and wound complications. So therefore, impaired control of sugar has these impact of the vascular catastrophes. And if we look at the patients who has diabetes or who has no diabetes, even with the stress hypoglycemia also, the patients have adverse events. The patient may not be diabetic, but because of the stress, the sugars go up, his A1C is normal. Even in those patients, the complications are pretty high. So therefore, controlling glycemia is of paramount importance. If we look at the guidelines by the American Diabetic Association in 2023, now the guideline looks at a different angle. It's more personalized than what it used to be, like everybody start metformin, then the first molecule, then add on the next molecule, and next it is not so anymore. What it says is the patient has established cardiovascular disease, or there's increased incidence of heart failure, or a chronic kidney disease. We have a special molecule like GLP receptor agonist and the SGLT2 inhibitors as the drugs of choice ahead of other drugs, even if the patient's A1C is not controlled. Look at the change in the impact of treating patients with diabetes by the guideline. And here also, when the weight loss is a major concern, in fact, the American Diabetic Association meeting in this year, the June, had 60% of the presentations on the weight loss as the major emphasis on treatment of diabetes. And you can see those drugs which have got a very highly efficacious, like dulaglutide, semaglutide, and the combinations of GLP, GIP receptor agonists, like tirzepatide and of course the drugs like rutatrutide. All these newer drugs have come in a big way, and which has the effect on reducing the blood pressure. It also looks at the effect on reducing weight I mentioned, and also when the patient can't afford to buy drugs, then what happens in those patients who are poor. We can prescribe like sulfonylureas and glitazones, and this is the social determinant of the health, which is also looked at by the American Diabetic Association guidelines. Further this year, the guideline also redefines the stress on these 4 pillars. And the first, of course, as I mentioned earlier, to reduce the adiposopathy, which is again most important impact. Second, to take care of the CV renal risk reduction. So it's a cardiometabolic and a renal reduction. Mental health and social determinants is also important. And now they added a most important metrics, and that is time in range. You need to get your patient in range so that the 70% of the time patient is between 70 milligrams to 180 milligrams. If that is achieved by the patient, then patient gets all benefits of good glycemic control. So these are the new pillars which we are now looking at the patients of management of diabetes, which is called the person-centered approach. This is the latest approach that we have when we look at the patient of diabetes. Now, the problem is when you look at patients of diabetes and the treatments available, there's a plethora of drugs with different actions, and there are multiple guidelines which tend to confuse people. And the conventional teaching is that during surgery or before anesthesia, we told all the drugs. And now there is again a different thought that you can continue some drugs, and some drugs are beneficial and they have a beneficial effect on the patient's outcome. So let's look at all those intricacies and see what we can best think of using these drugs intelligently in patients with diabetes undergoing surgery. So when you classify the anti-diabetic drugs, you classify them those who secrete insulin, or which is also called secretagogues, those who improve insulin resistance, and there are a lot of drugs which are there, like miscellaneous drugs like AGIs, the amylin analogs, the dopamine agonist, and the sodium glucose transporter inhibitor. And the newest class is the GLP receptor agonist oral one, besides injectable, which is semaglutide, which is available in 3, 7, and 14 milligrams. We'll touch upon the important molecules and see how they're important in terms of the outcome of the patient who goes for surgery. So before we dive deep into that, an important aspect to remember that general anesthesia increases the cortisol level, and therefore the sugars can go up by general anesthesia, while the spinal and epidural anesthesia has no effect on cortisol, and therefore the sugar may not be affected much. The spinal anesthesia decreases the catecholamine levels because of blockade of the sympathetic chain, and therefore you get a minimal drop in the blood pressure, but no change in the blood sugar levels. This is a very important quote by a very important diabetologist, and he says the diabetologists have the more concern about hyperglycemia, while surgeons, nurses, and particularly anesthetists have understandable but often irrational fear of hypoglycemia. So this is how the dualities of interest, the cardiologists and diabetologists are more interested in treating hyperglycemia, whereas surgeons and anesthetists are more worried about hypoglycemia. So that's how sometimes there is a discrepancy in the thought process, and therefore management of diabetes can be little irrational. Let's begin with the first molecule. When we talk of new molecules, we should also think of the older one, because they also have some kind of impact on these patients' management, and 50 to 60% of these patients taking these molecules as well. So talking about biguanides, which is the most important molecule, is metformin, the sole molecule. It reduces the production of glucose by the liver. It has also action of the transferring glucose by the blood force, especially in the adipose tissue in the muscle. It is a first-line treatment until 2022. In 2023, as I showed you a guideline, the metformin was not there. On the previous time, all the guidelines did mention that metformin is the first drug of choice, but it's no more, because there is no much evidence for metformin having superiority in terms of cardiovascular manifestation. Look at this study, which uses metformin in patients who are undergoing ambulatory surgery. And what it says that the patient does not have hypoglycemia when you use this molecule. So it's wise to continue these molecules during surgery, which are the ambulatory surgery. For example, the cataract surgery or a minor surgery where patient can continue bigonides. There is no need to stop bigonides when the patient is taking surgery. So remember that bigonides should not be stopped in the minor surgery, and therefore patient can continue with that. This is one study which looked at the patient with an impaired renal function. And these are 1 million patients which were studied, and they had GFR of less than 30. So anybody who has GFR of less than 30, now we look more at GFR other than creatinine value, because the GFR has got more impact in looking at the renal outcome. And therefore, it's interesting to know that we look at GFR. I must remind you that in the past, the US FDA has given the guideline that anybody has creatinine more than 1.6, you should stop it when the patient goes for surgery. It was realized when the patient stopped this molecule, the sugar started going up. And the patient filed a case against the US FDA, the first time in the history of US FDA. The patients filed a case against US FDA and they won the case. After that, now using the GFR as the cutoff values, do not go by the creatinine value, but go by the GFR. If it's less than 30, the risk of lactic acid is very high. Otherwise, the lactic acid does not occur if the GFR is more than 30. And why get lactic acidosis? Because the entire function of metformin is to prevent the lactate uptake from the liver. And what liver does is to convert the lactate into glucose. That is called Cori cycle. It was taught to us in the first MBBS physiology lecture. And what metformin does is stops that lactate being picked up by the liver. And therefore, lactate accumulates, and therefore you get lactic acidosis. Simple explanation why I get lactic acidosis. And therefore, remember, those with poor GFR or only one, we should not give the metformin, and those patients should not be taken for surgery, the GFR less than 30 on metformin. Now, there's one interesting study, which is the retrospective cohort study looking at 91,000 patients who are about 20 years of age who underwent surgery, any kind of surgery, a major surgery, all they mentioned here, skin, breast, musculoskeletal, respiratory, and so on and so forth. And what it was said is those patients who took metformin prior to surgery had a reduced mortality compared to those who are non-users. What does it mean? That metformin has many non-glycemic benefits, which are important. So therefore, except the low GFR, you can continue metformin in all those patients because it has a lot of beneficial effects. The next molecule is sulfonylurea. And we know that sulfonylurea works on the beta receptors. And what it does is it closes the potassium channel acting on the receptor. When it closes the potassium channel, the calcium channel opens up. And as the calcium walks inside, it brings about exocytosis of insulin. So insulin secretion is dependent on closure of potassium channel. And there are many kinds of sulfonylureas, the first generation, second generation. And the only problem with sulfonylureas is the hypoglycemia, because it sits on this receptor and blocks the potassium channel. Until this sulfonylurea sits here and blocks the potassium channel, the secretion of insulin will continue. So it's not glucose-dependent action, it's a glucose-independent action. Therefore, the hypoglycemia is pretty high. And this is, again, a meta-analysis which shows that the cardiovascular events are pretty high because of this property of increased hypoglycemic episodes. Therefore, ischemic reconditioning does not take place, and therefore there's increased cardiovascular mortality. So therefore, sulfonylureas are the drugs which have the bad name of causing cardiovascular events, and therefore there's also evidence showing that these are the patients who underwent monitoring of the blood glucose using CGM, and what they showed was there is a hypoglycemic episode. The patient did not have symptoms, so asymptomatic hypoglycemia. And what you should remember is the conventional recommendation to withdraw sulfonylurea is very important, appropriate during surgery, before surgery. You should withdraw sulfonylureas. TZD is another molecule which are also important, and it acts through the PPAR gamma receptor. It acts on the nucleus, so it takes very long time. To have the full efficacy of this drug, it takes at least 3 to 4 weeks. But the point is concerned with surgery and anesthetists is that this drug can be used because it does not produce hypoglycemia. And all the minor surgeries, the patient can continue this elective surgery, patient can continue this molecule and go on for surgery without any problem. DPP-4 inhibitors are also very interesting molecules. And what they do is they block the enzyme DPP-4. And what DPP does is that it inactivates GLP-GIP, which is produced in the intestine after eating food. So when you eat food, the GLP-GIP is produced by the K and L cells respectively, and these incretin hormones have action on the beta cells and alpha cells. By beta cell, they stimulate secretion of insulin, and alpha cell, they inhibit glucagon levels, and therefore the blood sugar is reduced. The problem with GLP is it's immediately destroyed within 2 minutes by DPP4. So if you give DPP4 inhibitor, you prolong the action of GLP-GIP, and therefore you get a prolonged action of the GLP-GIP and a good glycemic control. And these are the molecules we have: vildagliptin, sitagliptin, saxalina, teneligliptin, alogliptin. There are many of these molecules. They're very useful. They're small molecules. They're very effective. And now what is very interesting is they can be used in the ICU. There are 2 great studies which look at using linagliptin and sitagliptin, both used in the ICU setting, where they compared the use of this molecule with basal insulin versus basal bolus therapy. This is how the comparison is. And what it showed was that linagliptin and sitagliptin in these patients, when used against basal bolus therapy, showed a similar results without the risk of hypoglycemia. So, but these drugs now have stepped in the arena of treatment, even in the ICU, in the critical care setting. You can use them because the initial teaching was all the oral drugs to be stopped, patient gets admitted in a hospital, is no more true. Talking about the SGLT2 inhibitors, these are the drugs which work on the proximal tubule of the kidney, where the SGLT2 transporters are there. This is called sodium glucose cotransporters, and this inhibit this. And therefore, the glucose which is not excreted normally in the urine starts getting excreted in the urine. By putting off the SGLT2 inhibitor and the pumps, the glucose is excreted, and that glucose which is not absorbed back into circulation, that glycemic burden or a glucotoxicity on the beta cell is reduced. So it offloads the beta cell and improves the beta cell function, and also reduces the weight of these patients. As I said, the adiposopathy is a very important factor in managing diabetes, and therefore the inhibitors of this molecule become a big way. Now, what I must tell you is that these molecules have revolutionized the treatment of diabetes and even non-diabetic population. And the first study presented in 2015 at Sweden, at Stockholm, at the European Associate Study of Diabetes, was a most interesting and most thrilling experience for all those who attended the meeting. And as the presentation was going on, people were so excited to see the benefit of the molecule. They started clapping continuously throughout the lecture. And some of them were super excited. They stood up on the chair and started clapping because these molecules have made a tremendous change in the outcome. For the first time, these molecules have shown benefit in heart failure, in prevention of heart failure. They also showed benefit in preventing kidney disease. And is extended to the patients without diabetes, with heart failure, without diabetic kidneys, and did a similar miracle in these patients as well. Now, when you think of these drugs before surgery, what is the guideline says? The guideline says stop canagliflozin, dapagliflozin, empagliflozin 3 days prior to surgery, and stop ertugliflozin, which is not available in this country, 4 days prior to surgery. And why they say so? Because the half-life of this molecule is 11 to 13 hours. And what you need to have the 5 half-lives as the duration before the drug is washed away from circulation. So therefore, classically, 3 to 4 days, the patient has to stop this molecule before the patient goes for surgery. And why it's important? Because if this molecule remains in the circulation, there's a risk of what is called a euglycemic diabetic ketoacidosis, which we had forgotten with using only in treating with type 1 diabetes. But this is researched again or re-emerged again, especially with this molecule. When the sugars are not very high, 250, that's why it's called euglycemic, pH is low, and they're low bicarbonates, and there's a huge anion gap of more than 12. And remember, the risk factors are any procedure going on more than 1 hour under general anesthesia, and patient has got anticipation of nil by mouth by 12 hours, pre-op A1C is more than 8, pre-op glucose more than 150, patients taking insulin as outdoor patient, and a significant background comorbid like trauma, myocardial infarction, etc. Remember, this is a possibility that the patient can get euglycemic ketoacidosis because ketogenesis is the basis of these molecules' mechanism of action. If this exceeds, when you stop the insulin suddenly, there's an increased production of glucagon, which brings about lipolysis and therefore more ketone bodies, and you can get ketoacidosis. Ketosis is a normal process, but ketoacidosis is abnormal. And therefore, one has to remember this. So 3 to 4 days, you have to stop this molecule before the patient goes for surgery. Now, following that, there was an interesting study done recently in 2020 from Melbourne, which is called Journal of Perioperative Practice in Melbourne. And what they looked at 82 number of patients, and 16 of them, they withheld the SGLT2 prior to the surgery 3 to 4 days. And 66 patients, either the ignorance of a doctor or the patient's ignorance, these 66 patients continued the medication. And what did you see? And lo and behold, surprisingly, the patients who withheld the drug 3 to 4 days prior to surgery had more problems of postoperative complications and a reduced glycemic control. So there's a mixed approach now, mixed feeling now. Of course, the study is too small to say anything, but as of now, till the fresh studies come up and fresh guidelines come up, it's important to remember that you have to stop SGLT2 3 days prior to surgery. The next molecule further is called GLP receptor agonist, which was discovered accidentally by this great man called John Eng, who was working in Arizona in the people who came to him for treatment of acute abdominal pain. He realized there were bites by this particular reptile, which is called Gila monster. It's pronounced as Gila monster. It's written as Gila monster, pronounced as Gila monster. And this Gila monster spit had a substance which is called GLP receptor agonist. And now we have the analogs of this, the exendin molecule described by him, and these molecules which are called human GLP analogs. And we have in the market dulaglutide, which is once a week. Then we have liraglutide, semaglutide. Tirzepatide has not come to India still, but it is available in the Western countries. Now there's a study looking at using liraglutide prior to surgery compared with insulin therapy. These are 90 patients with 68 years of age in duration of diabetes of 10 to 14 years. And what they were given either liraglutide or insulin. And what you see here very carefully, in liraglutide and insulin, lira definitely scored over before surgery, and at the end of surgery, you can see the sugar levels were much lesser in the liraglutide compared to insulin, much more better, much more efficacious insulin. This is just to remind you that these drugs, the GLP receptor agonist, improve the beta cell function in just 24 hours. Can you believe that? There's no drug which can do like this, which improves the beta cell function within 24 hours. And these drugs have proved quite miraculous molecules, and they can see the effect yourself. And surgical patients are no exception for this benefit, which is called enhanced recovery after surgery protocols. And this is again interesting, just to remind you in case, this is from the internet. And this is the 50-year-old lady who has diabetes and obstructive sleep apnea and hypertension. She's scheduled for hysterectomy, and she was on dulaglutide. This is a Trulicity 3 milligram, a higher dose. In India, we use up to 1.5. This is 3 milligram. She had other concomitant therapy, also like metformin, hydrochlorothiazide, and she fasted night before going for surgery. She was intubated, and also the orogastric tube was put inside. Shortly before she was ready for extubation, she developed a large volumic emesis. This is how she vomited, and this vomitus contained a substance which she had eaten a few days earlier. That means most of these patients are diabetes or gastroparesis as a part of autonomic disturbances. And these molecules further delay the gastric emptying. So it's important to withhold this medication at least 1 week prior to the procedure. And remember, those patients who take oral GLP analogs, you can hold it for a day or two before surgery, but who take injectables or a weekly injectables, these are more powerful, though they are weekly, they're more powerful. You need to stop these drugs at least a week or two prior to. So this is the guideline by the American Society of Anesthesiology, and therefore the GLP receptor agonists have to stop much earlier, irrespective of what is the indication, whether it's for diabetes or weight loss, or whatever the dose it is, and what is the type and procedure that you're undertaking. You need to hold these drugs much ahead of time. So therefore, when you go for perioperative, GLP receptor agonist is held. When the patient is yes, no GI symptoms, you go proceed. When the patient has GI symptoms, you do an ultrasound and see the stomach is empty. If not, then if the stomach is empty, then go for the procedure. If it's not, Then either delay the procedure or you can cancel the procedure, or what is called a rapid sequence induction is possible. So therefore, remember a GL receptor agonist, you need to withdraw this. In the last 2 or 3 minutes that I have, I'll quickly run through the insulin because though topic was given to me on oral drugs, but just in the interest of this completion of the subject, in just 2 or 3 minutes, I'll run through the insulin. Remember, all patients admitted in the hospital, no oral drugs are normally recommended in the past. And all those critically ill patients, we give intravenous insulin. And those patients who are eating food, we can give the basal bolus insulin. And all those guidelines, whether it's SAMBA guideline, ADA guidelines, the American College of Physicians, all of them says that you have to act when the sugars go beyond 180. And we have many, many molecules for insulin that can be used. And whatever one you want to use, you can use it. You need a short-acting insulin. In the long-acting insulin, only NBH can be used. Glargine, Detimir, Degludec have not been tested in the ICU setting or in the hospital setting because of their predictability of the action is not well known. So therefore, NPH you stick to is older molecule, and any of these short-acting molecule or regular insulin you can use. That's very important. This is the rabbit study which looked at the use of the basal bolus insulin therapy. Here, of course, they use glargine therapy in this particular study called LABI-2 trial. And what it showed was that this is the better way of treating patients when they're hospitalized, and not to use what is called sliding scale insulin. Most of the nursing homes and some of the smaller nursing homes use the sliding scale insulin therapy, which is not correct because this is the post-effective mechanism of controlling sugar. They can bring about a lot of complications of diabetes. And the cost of therapy is also very high when you sliding scale insulin compared to basal insulin therapy. So always stick to basal bolus insulin in the hospitalized patient, not to use the sliding scale. The sliding scale gives you an erroneous way of treating patient diabetes. Patient can never get controlled, and the strength of the stay of the patient get delayed. A lot of patients now use this continuous glucose monitoring when they go for surgery. It's always better to take them off because we have a lot of problems with this because it's subcutaneous insulin injection, and this is the sensor which is subcutaneous, which tells you the blood sugar value of subcutaneous tissue, not the blood tissue. There's a lag between the subcutaneous glucose versus the blood glucose, and it's prudent to not to use these things when the patient is using them. You discard these for the time being, give them intravenous insulin and control their blood sugar and get them through the surgery. But if the patient is undergoing a small procedure like cataract surgery and all, you can use these kinds of devices which are now available. So they're expensive. A lot of patients, especially type 1, are using them. So just to complete the new discovery in insulin called Afrezza, which is the inhaled insulin, like how asthmatics takes the medication, they can take like this. This is approved by US FDA. It starts very quickly. Within 12 minutes, it works and wanes off within 3 hours. It's a short-acting insulin. So many patients of type 1 diabetes who are short-acting insulin, of course, you can use this for a short-acting preparation. But remember, this only controls the prandial sugar. For the basal control, you require a basal insulin. And for prevention of ketosis, you require a basal insulin. The most important function of basal insulin is to prevent ketosis. So no patient of type 1 diabetes can be managed without basal insulin. That should be kept in mind. The hypoglycemia can be decreased because it's very short acting and lasts for a short period of time. But patients who have asthma, who have chronic active lung disease, or a cancer or COPD, it cannot be used. And before the day of surgery, of course, you need to stop this as well. With that, I think I conclude my talk in saying that consensus regarding pertinent perioperative glucose target has achieved, but a strong evidence regarding improved perioperative outcome related to it is still lacking. Optimal anti-diabetic drug regimen should avoid severe hyperglycemia and hypoglycemia because that can increase the stay of the hospital and also mortality and morbidity. And recent advances in the drugs for the management of diabetes have provided opportunities for improved glycemic control, but the healthcare workers should be familiar with newer technology to overcome the associated therapeutic complexity, patient, staff confusion, and medication errors. With that, I conclude my talk. Thank you very much for the patient listening, and I'll stop sharing. If there are any queries, I'll be happy to answer.
Thank you, sir, for your wonderful lecture. There are a few questions on the chat box. For high-risk diabetic patients with high creatinine, should we check for the GFR for all patients who is undergoing a GA or a spinal anesthesia?
Yes, yes, it's important to check that because the renal status is very essential in the effective outcome of these patients, because renal complications can be not only of GFR but also electrolyte imbalance and also sugar values. The sugar starts going down and these patients experience hypoglycemia. So therefore, a renal function assessment of that and knowing that what is the status of kidney function is the most important. And now we assess these patients by two mechanisms. One is by GFR, and second, what we check also is the proteinuria. Both proteinuria and GFR are important during the surgery, before the surgery, even after the surgery, because sometimes a kind of a bleeding or a hypertension or there's a volume loss, these patients can get acute kidney injury and they can worsen the existing kidney function. So it's very important to see the renal health throughout the procedure of surgery.
In an emergency surgery, what do we do if the patient is on a GLP-1 agonist? I think you have explained
Yeah,
that.
I mean, this should be stopped early, but if the patient still wants to go for an emergency surgery, I think you have to cut endogastric tube and try and aspirate everything else.
Or
And
do a ultrasonography on table.
yeah, sonography on table, you can see and ensure the stomach is empty. That is for the legal purpose. If the patient aspirates after that, then becomes a problem, and this aspiration can produce complications subsequently.
So yeah, I think yes. Please elaborate on GLP-1 agonist. I think you've covered the entire thing very well, sir, in the perioperative period.
Yeah, remember GLP analogs are very interesting drugs, and they have really changed the management of diabetes. They bring down the sugar without hypoglycemia. If you think of insulin, they'll bring down the sugar well, but the hypoglycemia is the price that you pay for it. And here is the molecule which does not do that. And what is more interesting is that one injection of GLP receptor agonist or one tablet of GLP receptor agonist can improve the beta cell function in 24 hours, which no molecule can do. And we are now getting many more molecules in this particular area, which have really changed the outcome. As I mentioned to you earlier, that we have now GLP-GIP analog, which is the name of tirzepatide, which has brought the weight loss to a tune of 12 kilograms to 15 kilograms, something similar to bariatric surgery, and without any problems of hypoglycemia, good control. And the benefit in terms of cardiovascular, especially stroke, reduction of stroke is 20%, which no molecule has done. And that is how it improves the plasticity, it improves the patient's synaptic function so well that patient gets a rewarding benefit. These are the molecules which have become like nectar or amrut for patients of diabetes, which have changed the outcome, all those cardiovascular, cerebrovascular, whether it's diabetic or non-diabetic patients. And this is across the spectrum. And that benefit has come to non-diabetic as well. And therefore, these drugs have been stolen by other specialists from diabetes. The SGLT is stolen by cardiologists and nephrologists.
Yes. Yeah,
So we are very, very generous in giving these molecules to everybody.
So like nowadays we have seen this in all our cardiac patients before the bypass surgery, whenever they come for an emergency. So I guess they start with this drug 2 or 3 days prior to the surgery.
Yes, now that has been shown again because the size of infarct is also reduced, even in given an acute setting. So now, in the SGLT2, for example, they were always being treated when the patient is stabilized. And then you give this molecule to treat heart failure. Now we are giving within 24 hours, when the patient 6 liters of oxygen is going on. At that point of time, this impulse study, for example, using empagliflozin, has shown the outcome tremendously better. So therefore, I think the life of patients and of course the doctors is also improved very much with these molecules. And these molecules have been stopped early in all the studies. In the past, we had to stop these studies because of the harm produced by drug. And now we are stopping the molecules before, the study stopped before the completion is because the other group, the placebo group, is not getting the benefit of the active comparator. So therefore, the entire paradigm has changed. what's the role of statins, which is better, atorvastatin? This is little, which is different, little off the subject, but I can answer that. All the statins are good, whether atorva or rosuvastatin, but there's some important aspect. Rosuvastatin is much more potent, has a better effect on reducing the cholesterol compared to atorvastatin. So potency by rosuvastatin is better. But remember, rosuvastatin is unsafe in patients of renal failure, where atorvastatin is a drug of choice, because rosuvastatin is the water soluble, and therefore in the patient of impaired kidney function, the levels of creatinine start rising. So when you have a patient of impaired renal function, use atorvastatin and not rosuvastatin. Otherwise, rosuvastatin by and large is a very important molecule to control the cholesterol. The rosuvastatin at highest concentration can produce new onset diabetes. So you can create onset of diabetes by using this molecule. So drug-induced diabetes, and their higher dose was used. And the reason why you got this is because these patients had some impairment of the muscle function. And if you know the physiology, 75% of muscle uptake is of that of glucose. So the moment you eat food something, 75% of glucose goes to the muscle. So muscle forms important storage for the glucose. And these statins are known to cause impairment of the muscle function. That's why most of these patients complain of muscle pain, aches, and all that. And that could be the reason why the statin-induced diabetes can occur. And now the SGLT2 and GLP are called 21st century statins. They are, of course, better than statins because they do much better work than what the statin does. The number needed to treat with the SGLT2 is just 10, and that is statin is 40. So that is the difference in statin is. GLP needs to be careful in the HD, and how prone are the CA? Is this true? Yes, there are some reports of the GLP-1 causing the paracellular tumor in the thyroid, which is called medullary carcinoma of thyroid. In human beings, there are no receptors located in the parafollicular cells, or what's called the C cells. So there is a rodent data that it can produce the medullary carcinoma of thyroid. But as far as humans are concerned, there is no obvious data to say that these drugs can produce that. But if there's a family history of medullary carcinoma of thyroid, or if you've done the calcitonin levels, they're pretty high, then I think you should be careful in looking at the calcitonin level before you start therapy. But I think it's very, very less. It's described in rodents, but not in the routine population. The question is it in setup? GFR frequently is not possible. We have got a lot of apps now. You can just download the app of GFR, just key in the age of the patient, the sex of the patient, and the creatinine level. You get the ready-made answer in GFR. But remember, once you get GFR, the two GFR readings should be the identical. Remember, when patient has acute perturbation, like for example, patient starts vomiting in loose motion, and the creatinine goes up slightly because of the hemoconcentration and the acute drop in the GFR is possible natural. Okay, but the two readings, or three readings for that matter, at weekly intervals should be the same before you say that the GFR is abnormal, not just by one reading. Remember, that's very important. I think we covered subjects beyond the diabetes also, like statins. Anything else? About the pancreatitis and pancreatic cancer is also thought of when you use the GLP receptor agonist, but it is still not proven. But anybody who has pancreatitis or a pancreatic carcinoma also should not use GLP besides medullary carcinoma. Yeah, somebody is asking question. Amrapali?
No, sir.
So it was a wonderful time to talk to you all. It's the first time that I had interaction with an anesthetist, because always they are behind the mask. You know, we sometimes we don't identify them also who's who. Sometimes by just eye expression, we can recognize and identify them. The first time I'm seeing them without mask and in the open air. So it's a wonderful experience. And I thank all of you, especially Manisha, who's all the time calling me, telling me about updates. And I hope this was some useful talk for you. And if there are any more thing that you want me to do for this group, I'm very well. I can do that.
Thank you, sir. Thank you very
Thank
much.
you, sir. Thank you very much.
Thank
And
you.
I also want to thank Aruna madam for getting you on our forum. And I
Oh.
hope someday we'll have a live session as well. That will be very nice.
Thank you. Thank you very much. And can I leave the meeting, please? If it's okay, because I have one more lecture at 7 o'clock.
Yes, sir.
Yes, sir. Thank you, sir.
Thank you.
Thank you, sir. Thank you so much.
So let us start with our second lecture. This is by Ashwini Kanade. She's the research lead at Healing Fields Foundation. She's a PhD scholar, public health nutrition expert, registered dietitian, and a certified diabetic educator with more than 20 years of work experience. Her expertise is behavioral change, that is lifestyle management, and in non-communicable disease. Over to you, Ashwini.
Thank you, Doctor. Thank you, everybody, for inviting me and giving me this opportunity. I am audible and my screen is visible to everyone. Perfect. Yeah. Thank you so much. I'm overwhelmed to be a part of this esteemed discussion group. And I always say that whenever there is a speaker like Dr. Neglur who's talking before you, your work is half done because he sets the stage so well, and he all the participants are so active and listening to the speaker. So I think my job is half done, and I just have to ensure that I can just keep up to his 1 minute. I'm just trying to switch on my camera so that it better connects to everyone. Yeah. There were a few things I have just taken up from Sir's discussion. One is that at the initial stages, he just said that the entire focus of the MNTs for the patients to a more personalized flow, which fortunately we always talk about a personalized treatment for a person with a medical condition or without a medical condition. The diets never go, they are never a printed patterns to given to the patients or the clients. The latest market word is a client, not a patient. When a person comes to a dietitian to meet, he becomes a client and not a patient. Unfortunately, that is the fact. So just going back to Sir's discussion that the diet has to be, or the diet therapy has to be personalized to the concept that the benefits are seeked by the entire family, because unlike medicine, the person just pops in individually. Whereas the difference is that the diet usually is taken by the family. Very rarely, if it is not a kidney patient, very rarely the diet is for the entire family, which is cooked, and it is a component of a child who is 5 years old and a component of who is a grandfather who is almost 85 plus, and all the members together eat the same food which is cooked at the family. But at the same time, how it can be individualized, or how it can be get the best benefit of cooking a family, in eating a family meal to an individual, is the key today, what we have to address. I would like to discuss certain, I'm calling this entire session as a discussion session, and there are certain points I have put in place for my direction, and all the questions, all the suggestions are welcome here. Unlike medicine, diet has multiple aspects to it, and it is never right and wrong. The concept which you might have may fit into a different scenario, and the concept which I am going to talk today might fit into a different scenario. So I am currently not sitting here and not going to tell you that what you are thinking about diet is wrong and what I'm going to tell you about diet is right. And from tomorrow this is the way you have to think about diet. No, this is not the entire discussion. My slides are not. Oh, yes. So as rightly introduced by Dr. Parna, that November was a month of Diabetes Awareness Month. 14th November is celebrated as a Diabetes Day. I remember in my initial ages of starting of career, someone had told me that there is no concept of writing a diabetic diet. Please start rethinking about this concept. Please start rewriting about it, and now talk about healthy lifestyle. So in any of my conversations, wherever it is in healthy lifestyle, I am talking exclusively, holistically about all the patterns, very specific medical nutrition therapies such as kidney disease, liver disorders, cancers. They would need a very different therapy. But diet comes into a picture of preventive medicine. And here I'm talking about healthy lifestyle. So please don't think about a diabetic diet henceforth. The WHO definition is not new to anyone. WHO talks about a healthy lifestyle is the focus on incorporating the 8 concepts of well-being. In these 8 concepts, I am going to talk about physical activity, diet and physical activity, what I am concentrating today. We all, as sir had rightly taken you all to the first lecture of your MBBS degrees, I am just trying to help you understand what you eat in your plate, and when you look at your diet plate, what it consists of. There are different colors in your plate, and these different colors talk about carbohydrates, proteins, fats, fiber, vitamins, minerals, calcium, and iron. So we all know that carbohydrates are basically the energy-giving foods. Proteins are for the repair and growth. Fats are basically for the lubrication and for the cellular functioning. Fiber is for your gut health, for your overall health and disease prevention. Vitamins, minerals, calcium, iron have their own supportive and protective nature in the diet. So this is something interesting I would like to discuss with you is how much do Indians currently eat? We all include a typical diet, which is a family diet, a traditional diet. Different cultures have different traditions which are consumed. So this was a study conducted in 2020, and this study was done on Indians, and in Indians in every state this study was done, and different people from different economic strata were included in this study. So the study, the researchers concluded that the richest of the richest households consume somewhere around 3,000 calories per day per person. I'm sure everyone is aware of the calorie concept because that's a very glamorous word which is used everywhere. Calories is something everyone knows. Someone can just say, unmute and say, calories is something everyone knows, right?
Yeah.
Perfect. So that study said that across the different states, all the rich people, there were certain parameters with which they had defined which are rich people. They have consumed almost around 3,000 calories per day per person. The poorest households consume somewhere around 1,645 kilocalories per day. An average Indian total calories counted was 2,200 calories per day. These numbers are really very high numbers. And this another chart is trying to tell us that what exactly are the components of processed foods, components of whole foods, vegetables, fruits, animal foods in our diet. And when the Indian diet was compared with the other countries and with China, what we have seen that 39% of the Indian population is consuming processed foods very commonly. Only 23% of the population in India is consuming vegetables and fruits. Almost 27% of Indians are consuming animal foods as a part of their diet. And only 11% are consuming nuts and seeds. Now, we would need to have a different lecture to explain the importance of increasing the vegetable and fruit content. Of course, in one of us, the surveys, one of our question was vegetables and fruits, and I'll come to those numbers here. Why processed foods? Why it is good? Why it is bad? Why the consumption is increasing? What is the role of our dietary behaviors in that? What is the role of the FMCG companies? What is the role of the media? It itself is a big topic to be discussed. And the role of nuts and seeds is very well understood, but very poorly accepted by Indians. Now, when we saw about how much Indians are eating, let's understand what is that component of 3,000 which is going into the richest diet, whereas then 2,200 average diet going into an average Indian diet. So our diets across the states, the cereal content is 70%. Cereals are basically a basic source of carbohydrates. The cereals are everything such as rice, rotis, breads, jowar, bajra, oats, everything comes under cereals. Fruits and vegetables consumption is almost less than 40% of recommendations. And the protein is the lowest. This has been a study multiple years, multiple times. Different researchers have come up with the problem statement that protein intake in the Indian diet is very low. In spite of multiple problems arising due to protein intake is high. The protein intake is 6 to 8% only. I will also talk about what are the recommendations for proteins here. The same study also looked at the physical activity, because in spite of the 3000 calorie intake, it was not proportionate to the body weight percentage and also the physical activity. The sedentary behavior is very high in Indians. So only 34% of Indians are not doing any physical activity. We have this one question in our survey as well. So if this is the case in what India is currently consuming, what is the ICMR, that is the Indian Council of Medical Research, NIN, that is National Institute of Nutrition, talking about? They have given us from almost, Sir Gopalan has been working on the nutrient content for Indian consumptions from ages. And these guidelines have been, every 10 years, these guidelines keep revising. The latest which has come up is the 2020 guidelines. This is a little complex and these are little numbers. I'll just take a little extra time discussing this slide. So calories, when talking about, so NIN says that an adult man should weigh 65 kgs. That is an ideal body weight for a man. And adult woman should weigh 55 kgs. What is the current weight? Another topic of discussion. So calories, in our differentiation of calories or talking about calories, we always define a person's activity as sedentary activity, moderate activity, and heavy activity. Now it is a controversial topic whether all the anesthetists come into a moderate activity or a heavy activity or a sedentary activity, because the definitions according to WHO is very different. Having said that, the calorie requirement per sedentary activity for an adult man is 2110 kilocalories per day. And for a female, it is almost 1660 kilocalories per day. And that is increasing as the amount of physical activity increases. Having said that about calories, now let's come to the protein content. So protein currently actually has now become more of a topic to be discussed on media. What is the protein content? There are a lot of superstars or Bollywood stars who are talking about the protein requirement and the intake by the Indian people. So as per the NIN ICMR guidelines, 1 gram per kg body weight per day is the protein requirement. So if an adult has to be 65 kgs, the person intake has to be 165 grams. Not that if the person is weighing 100 kgs, the person should start having 100 kgs. That should not be the calculation, because it is going to have an adverse effect on the body. Similarly, there is a concept which is talked about cereal, legume, and milk composition ratio. There's a ratio when we talk about this. So the NIN says that in a day's diet, the cereal should have 3 components. Legume should have 1 component, and the milk should have almost 2.5 parts of it. This is how it becomes a complete ideal diet. When we talk about diet, there's one component which we cannot overlook, and that is oil. Unfortunately, whenever we give a lecture to a common man and medically illiterate person, the first person they say is, which kaunsa oil buy karna chahiye? And I feel very sorry for this, because this question never comes as how much oil should I buy for the good health of my family? And the answer is, it's half a kg per person per month. And there is no single oil which is good enough for the betterment of entire family's health. The requirements differ as per the age group. The requirement differs as per the physical activity. But a combination of MUFA, PUFA, and saturated fatty acids is always an ideal. So we traditionally, most of the Indian families have certain types of oil used for cooking, certain types of oil used only for the vaghar, shortenings used. There's always a ghee component added to your rice or rotis. So this is a combination of your MUFA, PUFA, and saturated fats, which has to be included regularly in your diet. So this is a little interesting now. So you have to answer these questions to yourself. I see that there were somewhere around 56 participants when we started, and we had run a survey yesterday, and we have received somewhere around 33 responses till evening 5:30. People who could not answer this survey, you can just answer it for yourself now. So the question was, do you experience food cravings? Do you consider food as a reward for a hard day? Do you reward yourself with a food during an achievement? And do you get upset with yourself for eating any unhealthy snack or meal? If the answer to any of the 4 questions, or at least all the 4 questions or any one question is yes, then the above questions may conclude that one person is could be a stress eater, and most of the time stress eating is not synonymous to healthy eating. So what happens where, and I'm going to give you some takeaway messages also, what we can have. So now, what are stress eating, what are comfort? If you might be aware of the word terminology, comfort food also. So many comfort foods. In my career of 20-25 years, I haven't heard anyone saying that Karela is my comfort food. Whenever I get a little hard day, I go and eat a Karela. So most of the time, the comfort food is either a fried snack, most of the time a packet food, and ice cream and chocolate. Sometimes maybe because of the age we might not eat, but given a choice, we would always prefer it, because ice creams and chocolates always, media is relating it to the younger age group than the senior age group. Hot beverages, specifically tea and coffee, are the very big comfort providers, and hard drinks at times. So do we have a solution? Yes, we do have a solution. What do we do about it? We can plan ahead, know your options, be assertive when in group. Usually when we go with friends or family for the common meals, we usually say, what do you want to order? Anything works for me. So most of the times your choice is not being discussed. Your choice, you are not able to express what you want to say, want to eat, or what you want to demand. And the food which is being served to you is basically a common food, or someone else's choice is being served to you. So we always say that be assertive, know what you want to eat. Today I want to eat pav bhaji, so it is, I know I need to have pav bhaji. Then I have to decide whether I'm going to have a butter pav bhaji, cheese pav bhaji, or some other pav bhaji. Then it differs there. Take charge of your thoughts. Exactly what are you craving for? Are you really craving for food? Then just think over it and then give an approach towards it. And eat well when away from home. So again, as I said, what Indians are eating is a big topic for discussion. Nutrients is a big topic for discussion. Similarly, plan ahead, know your options, be assertive, and take charge of your thoughts is a well-studied concept given by AD, American Diabetic Association. And this is basically in the diabetes prevention program, which is running for almost now more than 23 years across the globe. So they have given these terminologies, they have given these thoughts, they have given this framework to make yourself aware about your eating habits and how to be strong. So I will not discuss everything in detail. I will directly go to eat well when away from home. And most of the times when I was interacting with one of your colleagues, I realized that you might be experiencing regularly or sometimes a week a very stressful day. A stressful day, I mean, I would like to, the operational definition of stressful day here is basically a long case wherein you have been standing for hours together, maybe because of complications, maybe because of the nature of the surgery, or it could be that you were unwell and you still had committed for that work and you have reached that place. And secondly, that could be a physical stress as well as a mental stress. So what you do when you're away from home? So first thing is the survey. I'll tell you what our survey data says first and then give you the solutions. The survey data says that whichever is good, I am not highlighting that. Whichever is something which we need to, as an individual, look for. Let's look at those numbers. So 88% of the respondents said that food craving is very high. They have food craving. 73% said that they reward themselves with food when they have a hard day. Are everyone able to relate to this? This was a survey which we have just circulated a day before, because there were some participants who had not a part of the survey. So these were the questions which we had asked them. And 73% again said that I reward with food wherever there is an achievement. Achievement could be simple. It could be your achievement, your family member's achievement, any. But when you feel good, awareness, as we all know, as you all are from the medical fraternity, the awareness levels are very high. There is a knowledge, there is awareness. Sometimes they're missing, which is a practice. So you get upset when you're not eating unhealthy. You get upset when you're not eating an unhealthy meal. So there is an awareness about it. A guilt feeling aata hai. We also asked about, because I'm going to talk about the food label reading. We also asked the participants whether they read the label. So when we come to that slide, I'll explain what I'm meaning about food label. So there are 25% who in our responses who say that they do not read the food label. Good, bad, better, we can talk about it. And there are still in our group, we have 12% such people that who do not do any form of physical activity. People who are doing great. But this is something for them who have said that they do not do any physical activity. It is the starting time now. Okay, coming back to a hard day and food as a reward. These two behaviors are basically directly related to your psychology. Hard day is basically a stressful day, maybe a physical stress, a mental stress, wherein you feel low, थोड़ा कम लगता है, अच्छा नहीं लगता, upset the highest, and you are happy. Both the times. Am I audible? Because my internet seems to be unstable.
Yeah, you're audible.
Yeah. So both the times, either it is related to psychology. So we have to ensure that my body is not controlled by my mind. I am controlling my mind. This is something, my eating habits are a reason there we can relook at ourselves. So when I was talking to one of your colleagues, I just realized that you need to have some options ready, handy to eat, wherein you can avoid unhealthy eating outside or street food outside, which we can say unhealthy. And what are those options? So I'm just giving that 4 options. These 4 options are in the category of 1 is the most preferred, 4 is the 4 can be, it's okay. I mean, there are people who are vegetarian. I think majority of our participants have said that they are vegetarian. So boiled egg for them could be the least at the category. And the last column is talking about, no, this is not to be consumed. Okay, so early morning, what can you have is fruits, dry fruits, protein bars, or boiled eggs, or protein bars can be. Now this, when I say protein bars, they need not be the processed outside ones. You have the various simple recipes which you can be made at home and you can have that. There are a lot of simple protein bars. Simple could be your chickpea also. So you can have that as one of the options where you're leaving very early, because if your case starts somewhere around 6:30, then you've not even managed your breakfast that day. So then what? Please do not go for the work with only tea and biscuits. The worst thing you can do to your body and your mind is having tea and breakfast and starting a case. For breakfast, you can have any South Indian, freshly cooked. South Indians, I do not prefer. When you're eating outside, South Indians, I do not have in the second part of the day, because the food gets a little more fermented. The batter gets a little more fermented outside because it is not stored at the proper temperatures. And so South Indian eating in the second half of the day, usually the person feels bloating. Burping zyada hota hai. So I usually recommend South Indian only in the first half of the day. Dahi and paratha is one of the best and available across everywhere. Boiled eggs you can carry with yourself. Protein bars you can carry. Please do not have just a fruit juice or a canned juice or a sugar-free juice. We'll come to it. Why not just juices? Lunch you can have stuffed parathas. How many of you carry tiffin boxes? I didn't ask this question. It was a nice question to ask actually.
I carry.
They can reply in the chat. They can be wholesome. They can you can mix 2 or 3 flours together: wheat flour, chana flour, soybean flour, roasted soybean flour, or different flours and make it at home. You can make it a multigrain flour and add vegetables to it, add dals to it, add paneer to it, and you can just make a stuffed paratha for yourself. The name sounds a little more elaborative or exclusive, but it is a simple recipe. Sprouts can be consumed. Sprouts needs a little plan ahead, because sprouts you need to have soaked before and then carry. This is something very interesting, and I'm sure none of you must have thought about it. Sticks of cucumber and carrot with peanut butter, or sticks of apples with peanut butter. This is a very wholesome breakfast. You can have, or you can have it for your lunch as well. Multigrain. Now again, when I'm talking that less processed foods, I still have to give you an option of bread, because that is the convenient food today. So we have a little better choice by having a little multigrain breads there. Please do not have fried rice or Chinese items for your lunch. You are going to spoil your entire evening after eating that. Similarly, for dinners, wherever possible, if it is possible for you to close your activities and come home somewhere around 7:38, I know you're going to raise your eyebrows after these numbers, but how much as possible, if you can manage khichdi at early evenings, or you can have a proper full meal at 7:30. The later part of the day, try and have least minimum food intake. Please do not say that I had a very bad day. I have skipped all my meals in the day. I've not had anything healthy, unhealthy, kuch bhi nahi khaya hai. So I deserve a complete meal today. I am now going to have a nice meal. So I'm going to have my X number of chapatis. I'm going to have rice. I'm going to have dal. I'm going to have vegetables. I need my curd or my buttermilk, everything. I'm going to have a dessert as well. That would be a really big mess up we are going to do with our body. Our sleep are going to hampered. Our next day activities are going to hampered. Our bowel system is going to be hampered. So don't, please, whenever there's an early meal, late meal, have a light meal. Dalia khichdi is a very good option. You can have masala rotis, you can have soup and fresh salads, you can have. This is something now I am a little more appreciative about the fast food centers, because they have a variety of salads available. Indian culture, we still do not have so much of salad making at home, only because when you buy a salad, there is a major portion of which, in terms of time convenience, it's not time convenient. It is not portion convenient. It is not liked by everyone. So salad is I'm not talking about raita. I'm talking about salad. So salad is not very oftenly cooked by the family members at home. Whenever in dinners, please don't have maida-rich, butter-rich rotis or tadkas and dals and very heavy, wherein that color is as red as your blood. Please don't have those curries with the oil flowing everywhere. And then mid-meals, what you can have is, you can have roasted chanas, you can have popcorns, you can have fresh corns, you can have roasted makhanas, you can have dry bhels. Don't have diet bhel. You don't need to have that, because when you eat a diet bhel, at the end of that packet, you can see that everything is salt inside. So don't, and none of these, other than the bread, none of these are your packet foods. All you can actually make at home and eat from home. And a complete no, please, from your, tomorrow is 1st of December, in your grocery list, please do not get any Maggi. Please do not get any biscuits. Please do not get any chocolates. When you have to buy those breakfast cereals, you have to be very cautious what breakfast cereals are going to consume. Because lately what I've seen is, most of the families, I'm not saying you are doing it, most of the families, Maggi comes into your ration, which is very wrong. I'm sorry, I'm taking a name of a brand, but it is noodles which are coming into your brand house as a ration. You should not do that. So making a grocery list itself is very important. And I'm glad we are having this discussion today on the last day of the month, wherein most of the families are going to make a grocery list tomorrow. So after briefly discussing, because this can also take another one full lecture, ki what, when, how, where. But just as a take-home message, this is what you can eat and this is what you cannot eat. No is, I'm very firm that you should not eat this. The option 1, 2, 3, 4 can be better. If someone is a better cook than me, I'm sure you don't need to be a dietitian for that options. You need to be a little smart in terms of your choices and your observations, what you can actually make at home and carry with yourself. Now let's also please tell me, I missed noting the time when I started, how much time I have. I can just rush forward with covering the important points. Amrapali ji,
I know.
10 minutes more?
Yeah, 10 minutes.
Okay. So physical activity and diet concepts, we all know that exercise is very important, but there is a difference between a physical activity and an exercise. You might have experienced someone saying that I stand for a surgery and open heart surgery for 8 hours together. And then what do you expect me to do an exercise after this? I am already exerting. So there is a difference between exercise and physical activity. We need to understand that. As I rightly said, there is no food which is, let's not call the food and blame it with a junk food or a food, because a vada pav which is made outside, eaten outside, is always called as a junk food. But don't we as Indians cook vada pav at home at least 5 times a year? So do you say that junk food which is cooked at home, the food which is cooked at home also is a junk food? So it doesn't go by the definition. So we are going to talk about right time and wrong time, and we are going to, most probably this is something related to what sir was talking sometime back, was a diabetic friendly, a heart friendly, a zero fat diet, and what about it? So physical activity, exercise are two different concepts. However, physically active you. So one of my very senior doctor whom I was practicing with, Dr. Vinod Durandar, he had just once told a patient very, very strongly, very assertively, and the person was trying to tell doctor, doctor, मैं बहुत काम करती हूँ, I'm really very active entire day, and I don't think so कि whatever exercise you are telling me, I don't need that anymore. He said, I agree, madam. I completely agree. I know that none of us are ever sitting on the wheelchairs. Only a person who is sitting on a wheelchair or lying on the bed is not doing a physical activity. If you open the door 10 times to see who has come or answer a call, get up from a place and answer a landline call, you are moving and you are doing a physical activity, and I respect that. But that is not going to actually alleviate your reasons for not doing an exercise. Exercise is a very structured format, very specific to different muscles. And now Dr. Neglur had been talking about the role of muscles on glucose uptake and everything. Knowing the fact that we have to have that in weight reduction, we have to have an exercise which is muscle oriented, which is not machine oriented. I'm trying to say this here because we have certain participants who are using gym. I think 66 were walking, some 37 were doing yoga, and there was 12 or 15% who were doing gym also. So most of the time in the gym, not always, I'm again saying that not always all the muscles are utilized properly. But walking, yes, they are utilized to a certain extent. Yoga, too, yes, they are utilized to a certain extent. But physical activity and exercise, this is the major difference, that the proper structured, observed under the proper training, proper trainer is looking at you, and then you're performing an exercise. That is important, and that cannot have any pill. I'm sorry, exercise. We can have insulin inhalers, we can have everything, we can have diet pills, we can have pills to reduce our weight, but there is no pill which is going to help us burn our calories and replace it for the exercise. So it is very important, and we all need to be physically active. So let's not talk about, when talking about healthy food and unhealthy food, let's now move our concept from healthy and unhealthy to something which is right time and a wrong time. So most of the times it does happen that a meal which is consumed in a specific period of time was a requirement. And that's the reason it becomes a right time rather than becoming a junk food or an unhealthy food. For example, sometimes it could happen. I am sure it doesn't happen in India, but sausages are very commonly consumed in the even in the breakfast in the Western countries. So sausages per se, we do say that they are unhealthy, but if they are consumed in the right quantity at the right time, then it can be considered as a healthy food. So so rather than thinking about unhealthy and an unhealthy food, start thinking about the right time and a wrong time. That will help us to make major changes in our diet habits. Most of the times, whenever we are watching a TV and watching a serial commercial ad, we get a little carried away with the most attractive commercials, wherein they say that these product is now labeled as a diabetic friendly. So a diabetes person can start having this food and it is not going to hamper the sugar levels. This is very heart friendly. This has this component and it is cholesterol free and everything and everything and everything. It's a very complex activity. None of the foods can ever be only diabetic friendly. If one food is a sugar free, it need not be a fat free food. So if a diabetic has to think about it, the diabetic can think of one activity of it, which is a sugar component. However, talking about the fat component, which is also very important for a diabetic person in his diet, is not managed with these products. So very importantly, please don't get carried away with these concepts of diabetic friendly, heart friendly, zero fat diets. These are not the true actually to the terminologies. And to be aware of all these things, what do we need to have is, we need to have a food label literacy. Now, what is food label literacy is, most of the times whenever I randomly interact with people and I ask them, do you read a food label? So I was always surprised to have an answer yes. And when I ask, okay, okay, what do you read in that food label? The first thing comes to me is I look for the cost. I look for the expiry date. And unfortunately, that is one of the smallest thing which can be a contributor to a food label. A food label itself is a big information in a chart which is to be provided by all the FSSAI approved food products in the market. What does a food label basically talk about? It is talking about serving information that one packet can be consumed by how many people, every person, how many calories that one person is going to give. For example, you can just go back today to the market, and whenever you go to the market and check that one wafer packet, any company, you just check a wafer packet, on the backside of the packet, it is always written the number of servings. Most of the times, the bigger packet, which are the money savers, which we buy, which was bought or advertised during the COVID, the World Cup time, were the bigger packets, and they are not the one serving packets. I'm sure the serving size for that such packets are more than 4 to 5 people. But what happens as a human behavior, once a packet is opened, very rarely it is shared. In Indian families, just close your eyes and see for yourself and judge if this is happening at your family. An apple is cut and it is divided by 4 members of the family. The samosa is bought and it is consumed by single. We are not sharing that samosas. So this is how actually our health is getting impacted. Similarly, one packet of wafers, which was informed to me as a consumer that this is a packet of 4 people to be consumed, I have never read the food label. I have consumed it single-handedly on my own. So the 280 calories, which I see, acha 280 hi mila hai. But the 280 was something which only if I ate my share of that packet, but I have ate the share of all the 4 members in the family, and I've consumed everything. So this was an interesting study which was done in India again, wherein they had compared different categories. In males and females, of course, females look at the food labels more than when compared to females. In upper middle income and high income families, the upper middle income look more on the packets than the high income categories. And people in the age group of 20 to 30 are the maximum who look for the food labels, because I'm sure this is the age group which the person starts thinking about our self-image. How I look, how am I fat, am I thin, I am muscular. And that's the reason there is a lot of awareness in this age group, because 20 to 30 they read a food label. Again, this is only one aspect of the behavior, that is reading. It is awareness, it is knowledge, but is it converting to practices? Again, it will need a different this thing. And fortunately, married and unmarried, the unmarried ones actually look at the food labels more than the married ones. So last, I think 2 to 3 slides, I'll just run randomly to these questions. So whenever there is a dietitian talking or a person visiting a dietitian, it is always about a diet chart. And what is a diet chart? So there are researchers across the globe, and there are multiple patterns or types of diet which have come to surfaced and followed randomly, unadvised, short-lived, with inviting multiple health problems at an individual level, then going to specialist. I would not say only a dietitian, even to a physician, your family doctor. There's no conversation happening with the family doctors as well about this. So these are the diet patterns. These diet, again, I would not say that they are bad. You should not never follow them. There are cases when you need to follow a particular dietary regime. In sense, what happens is basically you have to eliminate certain types of food groups from your diet to get certain benefits. And that's how the diet becomes, for example, what do you say? Let's talk about gluten-free diet. So there are certain medical conditions with it related to your gut, wherein you cannot have any gluten, the protein content in the cereals. So you need to remove them from your diet. So that is a medically driven decisions, and that's the reason you do it. But what has happened lately? People have started following it very blindly, saying that if you want to lose weight, start having a gluten-free diet. Indians have been known to have chapatis as their staple food. Even the South Indians in India have the staple food. At least in one meal, they do have chapatis. Maybe one is completely rice-oriented, but one has chapatis. So if tomorrow you start telling a person who is an Indian whose staple food is wheat, remove wheat only for the benefit of weight loss, then it is an unfair decision given to them. Vegan diet. Vegan diet is basically talking about different ways, eliminating the poultry and the milk, animal origin products completely from your diet. This was started with certain group of people, and they had basically certain mindset of animal activists, you can say, some different form, and then that came up into the picture that the minute you start vegan diet, you start losing weight. So I think that again is not the right way of approaching it. There are different ways of having time restricted diets. There are intermittent fasting diets. I'm not taking the name of the doctors associated with these therapies. They are good. They are beneficial. They have shown impacts. But is it individualized? Is it long lasting? Can I follow that change? Because humans are social animals. So if I tell you that you should not eat anything when you're going out and meeting people, I'm sure you will stop eating. I mean, you'll stop being social again. Then that's going to hamper your mental health as well. So if there are multiple forms of diets available, please consult your medical professionals and then go ahead about it. Again, no diet is good or bad, but anything done in extremes without medical supervision is always bad. These are small, last two slides. These are just two small tips. I'm sure everyone knows about it. Always consult your doctor, please. Do a checkup, plan your food, keep it simple. Do not have an elaborate recipe. Vary your food. Humans are associating with colors. Humans are associating, food is very deeply associated with a satiety value. Satiety value is deeply associated with my emotions. So the more I have variety in my diet, I feel emotionally and mentally satisfied. And that is very important as a social human being here to survive. Start your day with a healthy breakfast. Never skip your breakfast. I think this is something we all have been learning from our childhood. Eat small and frequent meals if you are busy. If you feel that you are coming with some specific health components, then please consult your doctor and then have small and regular meals. Drink plenty of water. When you say plenty of water, again, there are multiple calculations and there are apps, as sir was saying, to simply calculate based on your height, your weight and your activity, what is your water requirement. On an average, 8 to 10 glasses is what you need daily to consume, to be healthy. Eat more healthy carbohydrates. When I say healthy carbohydrates, try and have, which is white in color, that is sugar, salt and maida. These three things have to go out of your kitchen and health actually comes in, walking easily. So these are the top 10 mantras. I'm sure every Google will help you understand this. 0 empty calories. What are empty calories? Another big lecture. 1 hour of reading always rejuvenates your health. 2 liters of water, which converts into 8 to 10 glasses. 3 cups of green tea or green juice. Green tea, again, another one lecture. But here I would not say only restrict to green tea, because excessive green tea also leads to dehydration. But at least some amount of natural antioxidant dose is very important for your body. 4 mental and stretches break is required if you're working for a very long time. I'm sure you will not take them when you're working on an open heart surgery. 5, you have to be grateful for your health. At least remember those 5 things. Meditation always helps. Even I think today one of the report which came was the Indian hockey team or the Indian football team have started doing a meditation sessions, and they had struggled for 6 months to get every player do that meditation session together. And because the people were not convinced that it is so important for improving my game. So meditation is very important, and there are a lot of research and lot of activities happening around that. Laughter is the best medicine. 8 hours of sleep is very important. Be away from your digital media as early as possible, and be in your bed at the right time every day at the same time. 9 p.m. sleep, I know it is not possible for people in Bombay especially. And 10,000 footsteps is very essential. I think 66% of people in our survey have said that they walk. So please count that you're walking for 10,000 steps, at least for 30 to 35. It is WHO says that 150 minutes per week is your walking target. So if you're walking, now the next step is that awareness that how much am I walking? Is it giving me the benefit? And then we can talk about brisk walking and normal walking. So these are the steps of how you can gradually improve your workouts. So lastly, I would say that don't start a diet that has an expiry date. Develop a healthy lifestyle. This will last forever. Thank you.
Thank you. Thank you. Thank you, Ashwini, for such a wonderful lecture. I think we are running
Pleasure.
out of time. So I guess the discussion
yeah, if you want to share those questions with me separately, and I should be answering them, just to with respect to time, just let me know. I'm okay with that.
Fine.
Just one.
Thank you, Anjali ma'am.
Yeah, Manisha.
Thank you. Thank you, Shweta ma'am.
I think 1 or 2 questions are there. We can just quickly answer them, Ashwini.
Dikshit
Yes,
diet.
yes.
They have asked, people have asked about Dikshit diet. Is it good?
I would, he is a very senior person from the medical profession. The problem with Dikshit diet, what has happened is there are certain set of people who have benefited from it. There are certain set of people who have not benefited from it. And the reason behind that is we have just understood Dikshit diet from a very bird's view concept. When Dr. Dikshit is talking about the dietary habits, there is a process what we need to have in that 45 minutes. When I say process, there is the selection of food, there is a quantity of the food which you have to consume, and how much and how fast you can consume in that 45 minutes. The only concept which a common man has understood is that I can eat in 2 intervals, and in 45 minutes I can eat anything. So they actually count that 45 minutes on the clock, and they start eating right from pizza to a vada pav to your roti, sabzi, everything in that 45 minutes. And I'm very sorry to say that however it is time restricted, it is also calorie defined. You cannot have. So what is intermittent fasting? What is Dikshit diet? Everything is basically you are controlling the amount of calories which you're going to intake. So you give me any name, you can tomorrow call your name and just say any diet form. The concept is calorie restriction and nothing more than that. So a Dikshit diet also has not worked with a lot of people because they have not understood the details about it.
Okay. Some light on millets versus wheat consumption.
Yeah. So 2023 is a millet year announced by the government. So millets are good. They are better nutrient composition when compared to wheat. But end of the day, it also has the same nutritional properties. components are different, they are a little high. So fiber is high, minerals are a little high in the millet component. So it doesn't mean that I can actually oversee my quantity. Again, the point comes in here is the portion control. I cannot have 3 bhakris or 3 rotis of jowar and bajra or ragi because they are millet and they are good. Versus ideally I was having just 2 chapatis, the wheat flour made chapatis. Millets are good, but again done in excess is not healthy.
Okay. I think we can go ahead with the second part of the session.
Sure.
So thank you.
Pleasure.
So yeah, we'll start with a video recipe. The first will be presented by Dr. Manisha Ghosh. Manisha Ghosh.
I am not able to hear the volume for this. Yeah. Devan, what do you want? One bit. बेसन का लाडू बनवून देऊ काय पाहिजे
Can't hear you.
Manisha, you're not audible. It is a recorded video and I am not sharing it. So Ganesh will have to look into that. I'm
Ganesh?
not sharing it.
गणेश सुनाई नहीं दे रहा है वीडियो.
Anyway, so this is a chana chaat recipe. We have some black chanas which have been soaked and boiled, soaked overnight and then boiled. And then we have our usual boiled peanuts. आहे का आवाज अजून नाही ना? Onions, tomatoes, green chilies, coriander, lemon juice, salt, red chili
आवाज
powder.
येतोय का आता?
नाही येत आहे. मीच बोलतीये. गणेश तुम्ही चालू ठेवा मीच बोलते जाऊ दे. Let's not waste time. So the boiled chana, the peanuts, finely chopped onions, tomatoes, lemon juice, green coriander has all been added together. There is some rock salt as well for extra taste. And we have mixed up everything and then topped it with some pomegranate seeds. So this is like a evening snack which can be tasty, umami, yummy and also healthy at one and the same time. I hope you all like it. Ganesh, please look into the video for the next one, huh? Video and sound.
Thank you, Dr. Manisha. It was a nice recipe. Short and sweet.
I will share it on WhatsApp group. There was no sound here. Ganesh, please make sure the next video has sound.
Yes, madam.
Yeah.
We can include this into the options also. Sprout salad.
I hope it was a healthy recipe, Ashwini.
Yes, it was. It was indeed a healthy recipe.
Yes, you can add it to your table next time.
Yeah, exactly.
Thank you. Next video, please, Ganesh.
Yes, madam.
So next video is by Dr. Ashwini.
शेअर करतो मी जरा मला. It is audible. Hello.
Yes, it is audible. You can just increase the volume little.
And is low in fat content. So let's quote the ingredients. With these ingredients, 6 servings of soup can be made. The ingredients are 1 cup of red lentil dal or masoor dal, which is soaked for 2 hours and drained, 1 tablespoon of olive oil, 1 medium-sized onion, finely chopped, 1 medium-sized carrot, diced finely, 3 tablespoons of freshly prepared tomato puree, 4 to 5 garlic cloves, which are minced, 1 teaspoon of paprika, half teaspoon of cumin powder, 1/4 teaspoon of black pepper powder, salt to taste, for garnishing, parsley, 1 tablespoon of lemon juice, and chili oil. This chili oil is prepared by heating olive oil, putting on the flame, and then adding chili flakes to the oil.
Coming back to the main recipe, take a thick bottom vessel and put it on the flame. Put the olive oil and allow it to heat. Let the olive oil heat, and after it is heated up, add onion, add carrots, and then saute this for 8 to 10 minutes till the onions and the carrots soften.
Now that the onion and carrots have softened, we will add the minced garlic, tomato puree, paprika powder, cumin powder, black pepper powder, and now we will saute the mixture for a few more minutes. Next, add the red lentil dal or the masoor dal, according to the taste, and 3 cups of warm water. Bring the mixture to boil. Once it starts boiling, reduce the flame to medium. Cover the vessel with a lid and let it simmer for 15 minutes for the dal to cook to a very soft consistency. Now that the dal has cooked very well, we will put on the flame and allow the mixture to cool down. Once it has cooled down, we will blend this mixture in a mixer or with a hand blender. Now that we have got a good consistency of the soup after blending, we transfer the soup to the vessel and reheat it before serving. We are almost ready with the soup. We can adjust the consistency of the soup as per our liking. So this soup is almost ready, which is high in proteins, is rich in the dietary fibers, it has got low glycemic index, low fat content, and it has got nutrients like folate, iron, calcium, magnesium, potassium, and phosphorus, and also antioxidants like polyphenols, which are cardioprotective. This soup gives a feeling of fullness and satiety, and it helps in weight management. So now, just before serving this soup, we add in the lemon juice. After adding the lemon juice, we transfer the soup to the soup bowl. The soup is garnished with the chili oil we prepared and with parsley. And now it is ready to serve. So bon appetit. Yeah, Amrapali.
Dr. Ashwin, it was a wonderful recipe. Can we start with the children's video? The first presentation is by Eva Joshi. Eva Joshi. गणेश आवाज क्लियर नहीं है. ब्रेक होतोय आवाज. गणेश.
मॅम तो व्हिडिओचा प्रॉब्लेम आहे म्हणतो. माझ्याकडनं व्यवस्थित चालू आहे इकडनं.
The second video by Ishan Joshi. Now the video will be presented by Ishan Joshi.
Rajan Joshi, sir, are you there? Dr. Rajan Joshi?
जगात घाली थैमान पायान से नाम प्राण या ओ कोवडाला कोवडा कोवडाला तिवारी भीमा टायमिंग कोणाला सांग कोवडा
महाराज पण या कोविडचा उतारा काय
कोविडचा उतार रोज मास्क हात सॅनिटाईज करा आणि थोडंच लांबच बसा अहो कोविड आला कोविड आला कोविड आला दिवारे दिवा आणि वॅक्सिनच्या कोविड
गणेश हा व्हिडिओ ऐकूच आला नाही.
So these two kids are the grandchildren of our dear Dr. Rajan Joshi sir, and they live in America. They were born there. They don't speak Marathi well, but they are trying to learn, and yet they are able to sing in Marathi, which many of our children living here might not be doing. So it's highly creditable that they are being taught the Marathi songs in America.
दुसरी बदलायची तिथेच आहे सगळी.
Ganesh, please take care of video audio.
Yes, madam.
The next song, Preksha Patel.
My name is Preksha Patil, the daughter of Dr. Shweta Hemant Patil. I am 11 years old and I am studying in 5th standard of Shrimati Sulochana Devi Singhania School. I play basketball and I am currently representing for my school in the school competitions. Last year, I got the opportunity to write short stories on the Bree Books platform. To name a few of my books, I would say Cute Pets, Trapezonia Nile Castle, The Toy World, and Adit and His Adventures. Last year, I also received the Good Samaritan Award. My hobbies includes the pebble painting and the coffee painting. Thank you, everyone.
So Preksha is a very, very versatile child, and she's been a great help to us in a lot of our programs where she has taken care of the technical. She's been the technical support of her mother, Shweta, who is another strong pillar of our branch. So Preksha is my favorite child, I must say.
Thank you, Manisha. Today also she is gone for her inter-school basketball match. So she is not here. Otherwise, I would have shown her also.
Thank you, Shweta.
Thank you, Shweta. So next video by Karthik Tarapur.
I'm Dr. Kavita Tarapur. My son Karthik Tarapur will play live basically. If we can stop the video, it will be better. He'll play live a song.
गणेश वीडियो मत प्ले करो.
Yes, madam. Yes.
Yeah.
I'll tell him to start.
Please, you can start.
Yeah. He's singing a song, Tera Mujhse.
Kavita, we can't hear.
Can't hear.
Yeah. You can hear now?
Can hear you, but can't hear the song.
Okay, now it's okay? Karthik, thoda आवाज बढ़ा दे.
Yeah, you can start. You can start. Karthik, you start. आज तो 15, 12.
Thank you. Was he audible?
Yeah. Mast. Sundar.
Thank you.
He has a very sweet voice.
Yeah, he's learning classical music plus keyboard from last 5 years.
That's nice. I think we would love to hear him live in our cultural program.
Yeah, definitely, ma'am.
Thank you, Kavita.
Yeah, thank you.
Thank you. Now the next video by Dr. Rahul Shah.
Am I audible?
Yes,
Am I-
ma'am. Yes, ma'am.
Should I introduce him?
Yes, ma'am.
Yes.
I'm Dr. Ela Shah. My son, Dr. Rahul Manar Shah, is an oral and maxillofacial surgeon since 2014. He has placed maximum number of zygoma implants globally, over 250, using Nevident technology. He has a copyright for the technique to use Nevident for placement of zygomatic implants to his name. He is very passionate about technology, surgery, and technology in surgery. He is pursuing it the same with extreme dedication. To that end, he has started his PhD and hope to be successful in that too with your blessings. Show the video, please.
Practicing at Sahyog Maxillofacial Center at Thane, Pachpakhad. I have started using digital technology in the field of dentistry and maxillofacial surgery since 2017. I was the first to introduce navigational technology in the field of dental implants and maxillofacial surgeries like orthodontic surgery for resection and rehabilitation of resected jaws. I also have a copyright for the technique to use dynamic navigation in zygomatic implants. Zygomatic implants are very relevant today, especially post-COVID, where due to mucor infections, there were a lot of maxillectomies performed. Zygomatic implant help us to restore these resected maxillas. Currently, I'm pursuing my PhD in dynamic navigation, and my topic is related to orthodontic surgery. This is the first of its kind study where dynamic navigation would be used for repositioning of the upper jaw. Myself and my wife, Dr. Saili, we have complete array of digital technology in dentistry and maxillofacial surgery, which basically starts from CBCT, which is data acquisition. We have intraoral scanners, we have various softwares, and we have milling machines as well as 3D printing machines, which help us fabricate our prosthesis in-house. I have also conducted various workshops and trained various dentists all over the world, including Europe, US, and India.
That's wonderful, madam. It's so heartening that one of our own bachas has grown up so big that he now has something which is, globally recognized, and he'll have a patent to his name soon. So it's a proud moment for us because we have seen him grow up in front of us. And also now he's doing wonderful practice, and all the best to him and to you as well.
Thank you.
Yeah. I think we can conclude now. Nilima, will you please give the vote of thanks?
Hello.
Yeah, Nilima.
Yes. It was such a wonderful evening. We didn't realize how the time flies. Thank you very much, Dr. Vijay Neglur, sir, for a very crisp presentation. I think his every slide was important. And I'm sure every one of us will want to go through the YouTube recording later on to grasp the entire lecture again. As sir said, with new drug coming in, now the approach is person-oriented and person-centered approach. So we have think about that. And thank you very much, Ashwini. It was a very nice presentation. We all know what is healthy diet and we keep hearing about it. But I think Ashwini gave us a different perspective about healthy eating. And she also gave us some practical solutions and options. And thank you all the parents for the lovely videos. And thank you, Manisha and Dr. Ashwini for those healthy recipes. I thank you, Thane ISA, for conducting such a beautiful webinar with a different concept. Thank you, Dr. Manisha Ghosh, who is the current president of Thane ISA. Thank you, Dr. Sunil Katkade, sir, who is the founder, president, and GC member of Thane ISA. Thank you, Dr. Parna Thakkar, who is the honorary secretary of Thane ISA. And I thank all the seniors who from SAM, so all the senior dignitaries from SAM who attended the webinar. Thank you so much. Thank you, Mr. Ganesh from Geneca Technology. Thank you, everybody. And thank you all the members of Thane ISA and from other branches who attended the webinar. Thank you.
Before we leave, just one or two announcements, Nilima.
1 second, and thank you, Dr. Amrapali, for moderating it so nice. Thank you.
Just announcements. We are having our next webinar on the 14th of December. So we will be giving you information about that soon. Please attend that also in large numbers. And then in the month of January, we are having a seminar for OT assistants to make our life better. And a well-informed OT assistant is always of great help. On 14th of January, we are having a marathon, which is being organized by Dr. Katkade sir and Solaris Hospital. So we will be providing medical support for that, and also listening to Ashwini after we'll go and start exercising from tomorrow so that we are fit to run those kilometers in January. And then there are many programs which I'm sure all of us will attend. Dr. Katkade sir, you want to say anything? Unmute sir, unmute kara.
See, this race is on 14th of Sunday morning, 14th of January, Sunday morning. It will be at Godbandar Road. We are expecting at least a participation about 1200 to 1500 members. The motto of the race, marathon, half marathon, is to make a common people aware of the neurological diseases like a spine or a brain diseases. They can be very well cured and taken care of. So that is the motto of that is the purpose of this half marathon. I request all ISA members and members of Thane Anesthesia and medical faculty to participate. Thank you. Kindly block your date. 14 January, Sunday morning, from 5 a.m. to about 8:39 a.m. Thank you. Thank you very much.
Thank you, everybody. Thank you, Nilima. Thank you, sir. Thank you, Amrapali. Thank you, everybody, for attending.
Thank you. Good night. Stay safe.